Okay, I'll give it a minute and I can start the introduction. And, Dr. Umbel is also here today. Okay, I think we have a forum here. So I'd like to welcome you all for our next session of the AAP section of Neonatal Perinatal Medicine Journal Club webinar. It's a pleasure to have Dr. Christy Waterberg and Dr. Wes Onlin today for this. Today's topic is hydrocortisone to improve survival without BPD. And our first author is Dr. Waterberg, which was published in NEJM in 2022 for it. And I presented today is Kosuke Tanaka. He's an MD PhD from University of Tokyo, Japan, and he's also doing an visiting research fellowship at UAB for us. So I'd like to introduce Dr. Waterberg. She's a professor emeritus of pediatrics division of neonatology at University of New Mexico. She was a former division chief there and has over 30 years experience conducting studies involving newborn adrenal function, its relationship to inflammation and BPD, and long-term outcomes after preterm birth. She also served as the PI for the NICST network and also served on the committee for fetus and newborn. She was also elected for the Society of Pediatric Research and American Pediatric Society Outstanding Clinical Researcher. And we're very grateful for her to have her here and spend her precious time with us. And it's also my pleasure to welcome Dr. Wes Onlin all the way from Netherlands. He's a professor of pediatrics at Emma Children's Hospital at Amsterdam Medical University in Netherlands. He did his MD PhD training in Netherlands and has gotten extensive training in various other countries, including Israel, Tanzania, and at Children's of LA in USA. So his primary interest is also in studying adrenal steroids and BPD and has published multiple blockbuster papers in this domain. And I just learned today that he's also a blockbuster musician. So it's our pleasure to welcome both of them here. And we're very grateful for Dr. Tanaka to also make time for this presentation. Just some housekeeping stuff. During the presentation, the mentors, which will be Dr. Onlin and Dr. Waterberg, are free to interrupt the presentation for any teaching point. If any other members have any questions, please put them in the chat and we'll go through it in the end as time allows for it. And with that, we can move forward. Dr. Tanaka, do you want to start the presentation, please? Kosuke, you're muted.
Sorry, I'm a little bit nervous. I'm Kosuke Tanaka, and I'm a neonatologist from Japan and a postdoctoral fellow in the University of Alabama at Birmingham. Thank you for giving me this opportunity to present today. I have no conflict of financial interest or disclosure concerning the presentation. The article that was picked today is Hydrocortisone to improve survival without bronchopulmonary dysplasia. And this was done by Dr. Christy Waterberg, who is kindly moderating on our session today along with Dr. Wes Onlin. This is published in the New England Journal of Medicine in 2022. As I review the article, I will be going through the consult checklist for reporting randomized controlled trials. Now highlight these checklist items with included in the article. The next two slides look at the different checklist items and each section. This paper contains most of the information required for reporting randomized controlled trials. Before I start reviewing the article, I want to briefly explain an overview of bronchopulmonary dysplasia and its treatment with glucocorticoid. I want to discuss important points regarding the treatment of BPD with glucocorticoid, as well as the benefit and harms of glucocorticoid therapy. Bronchopulmonary dysplasia is prevalent among infants born extremely preterm babies, affecting approximately half of the survivors, and its incidence has not shown a decline over time. The development of BPD is influenced by various factors, including prematurity, mechanical ventilation, exposure to oxygen, and inflammation, all of which contribute to its multifactorial nature. Diagnosis of BPD is associated with subsequent issues such as abnormal growth, neurodevelopment complications, and impairment of respiratory function. Unfortunately, the available treatment options for BPD have limited therapeutic effectiveness and are constrained by potential side effects, making it challenging to find optimal treatment. Currently, there is no established definitive treatment for BPD. However, glucocorticoids are considered one of the treatment options. In the 90s, dexamethasone was widely used to provide short-term respiratory benefits in the treatment of BPD. However, there have been reports of adverse effects associated with dexamethasone, including neurodevelopmental issues like cognitive impairment and cerebral palsy. According to a systematic review published in the Cochrane database in 2021, dexamethasone likely reduces the combined outcome of mortality or BPD at 36 weeks post-menstrual age. Despite the potential risks, many extreme preterm infants are still being exposed to dexamethasone as a treatment option for BPD. So to fully understand the discussion regarding the treatment of BPD with glucocorticoids, it is necessary to understand their benefit and harms. Some benefits of the treatment include reducing inflammation and improving short-term respiratory outcomes. So it may avoid adverse outcomes associated with long-term ventilation. Conversely, the harms of glucocorticoid include adverse neurodevelopmental effects, suppression of cortisol production, risk of hyperglycemia, hypertension, sepsis, and intestinal perforation. When deciding whether to use glucocorticoids as a treatment, weighing these benefits and harm is crucial. So in the context of steroids treatment for bronchopulmonary dysplasia, there are three key considerations to address: the type of steroids, timing of administration, and dose selection. But, sorry, is it okay?
Dr. Waterberg, I think it's a good time to review the history of steroids on BPD. You have extensively worked on this from us advocating steroids, and then suddenly with the new data coming, we stopped using it and the pendulum swinging back to us using again. So for all the new learners here, do you mind reviewing us the history of how the steroids have changed and how we have come this far?
Sure. It started out with a couple of studies in the late 80s, and they were all very small. There was Mark Mamel's crossover study of 6 babies with established BPD and showed short-term benefit. There was Gordon Avery's study of 16, I think, tied pair design, also showing short-term benefit. And then finally, Cummings, who was published in the New England Journal with only 36 babies, and those 36 babies were divided into 3 groups, and again showed short-term benefit from the high-dose prolonged therapy of 42 days. So we started to see this, even though Mark Mamel, when he published it, said, you know, we have to look at all kinds of issues before it gets into wide circulation. People started using it. And then gradually the adverse effects, particularly long-term adverse effects, began piling up. And around about 2000, I think Keith Barrington published his meta-analysis in 2001, maybe, showing that in multi-center trials, the babies who were treated with that kind of dosing of dexamethasone ended up with significant neurologic deficits. And so you saw, as you said, the pendulum swinging away from that. My path was a bit different in that I was interested in early inflammation and how inadequate adrenal function may play into that. And so I was looking first at cortisol in extremely preterm infants, and was it related to the onset of BPD? And certainly we found that lower cortisol and lower response to ACTH in the first week of life predicted BPD as an outcome, statistically. Certainly not for any individual baby. And so I started looking then at using low dose physiologic replacement of hydrocortisone early in life to see if we could alter that trajectory. And so my first pilot study looked good. The second one had a lot of problems. It was stopped because of an increased incidence of GI perforation, which turned out to be from concurrent administration of hydrocortisone and indomethacin. Is something we don't see if we don't have indomethacin associated with hydrocortisone use. So then it kind of went into dormancy for a while, and then Olivier Baude did the Premilox study in France, enrolling over 500 babies and showing that indeed hydrocortisone given early in low doses was associated with an improvement in the outcome of survival without BPD. So we've come around. So some people are using that and some people are not. And we did an individual patient data meta-analysis showing that, again, it is beneficial in terms of BPD and outcomes. It is associated with an increase in late onset sepsis while the kids are in the nursery. But in spite of that, there was no increased length of stay and there was no apparent adverse effect on neurodevelopmental outcomes at 2 years. So that's sort of where we are with that. And then we came back to using hydrocortisone in higher doses later on. And Wes Onlin and the group in the Netherlands has been very involved in looking at hydrocortisone for many years. And I'm sure he has additions to the story.
So, Dr. Onlin, so I know that with how things were changing with the AAP guidelines coming out, how is the scenario in Europe that time? Were the clinicians there agreeing about we are using too much steroids, or how things were doing and how it led to your work?
I think that everybody around the world at that time was wondering, are we doing the right thing? Because still infants were treated with steroids, but the treatment was postponed. The doses of dexamethasone was lowered. And we didn't know if that was the right thing, or should we use an alternative like hydrocortisone. And I would like to bring up for me, a landmark paper by Lex Doyle, where he showed that we had to have a discussion about whether we should make it a prophylactic therapy or a targeted therapy. In 2004, I think, but he did an update in 2014. He reviewed all the placebo-controlled dexamethasone trials, and then did a meta-regression, dividing the trials according to their risk of BPD, the percentage of the BPD in the placebo group. And what he saw is that when the trials having a low risk of BPD had an increased risk of neurodevelopmental adverse outcomes, whereas when you have a high risk of BPD, then the use of steroids, and this is dexamethasone, gives a decreased risk of neurodevelopmental impairment at 2 years of age. So it's a complex disease, BPD, because it's not only when to start corticosteroids, but also which corticosteroid, or even, and then if we know which one, which dose at what timing. And that makes it really complicated because BPD itself is persistently associated with an adverse outcome on long-term neurodevelopmental outcome. So not treating might not also be the best option.
Interesting. So, Koska, you want to proceed with the presentation? You're muted.
So 3 important points for steroids for BPD is first, what type of steroids? The options typically considered include dexamethasone and hydrocortisone. Other options include inhaled steroids. Inhaled steroids may have a lower risk of undesirable side effects compared to systemic steroids, but this is not the topic of today's discussion and will not be discussed further here. Evaluating the effectiveness and potential side effect of each option is crucial. Moving to the next, timing of steroid administration. This factor plays a significant role in the management of BPD. There are two main options to consider: early administration, which refers to administration within the first 7 days of life, which sometimes means prophylactic, or late, which indicates after the 7 days. Each timing has its implications and is evaluated separately when assessing the effectiveness of treatment. The third is dose selection. Dexamethasone was often administered in higher doses in the past than it is today, and you have to be careful when reviewing studies on its therapeutic efficacy. Also, with respect to hydrocortisone, it's easier to understand when physiologic doses are considered in mind. Now, I will briefly discuss the difference between hydrocortisone and dexamethasone. Hydrocortisone is a short-acting steroid, primarily known for its glucocorticoid activity. However, at supraphysiologic doses, it can also exhibit mineralocorticoid activity. Because dexamethasone used to be the mainstay of treatment for BPD, there are fewer studies on hydrocortisone. The potential advantage of hydrocortisone is that it may not have the apoptotic effects on the hippocampus observed with dexamethasone, and therefore has a lower risk of long-term neurodevelopmental impairment or cerebral palsy associated with hydrocortisone use. These advantages are thought to be due to hydrocortisone's ability to bind to the brain's mineralocorticoid and glucocorticoid receptors and balance these signals. On the other hand, dexamethasone has a longer duration of action and is historically more widely used in the treatment of BPD compared to hydrocortisone. It is potent glucocorticoid agonist, approximately 25 times more potent than hydrocortisone. There is stronger evidence supporting the use of dexamethasone in reducing the incidence of BPD. However, it is important to consider the potential long-term effects. Studies have reported an increased incidence of long-term neurodevelopmental impairment, particularly cerebral palsy, associated with dexamethasone use.
So Kosuke, can I make one point in that slide?
Thank you.
I think
Please.
that it's a little bit backwards on the glucocorticoid versus mineralocorticoid activity for hydrocortisone. I think at low doses, it occupies mineralocorticoid receptors, and at higher doses, it will occupy the glucocorticoid receptors in the hippocampus. And that's one reason that high stress for a prolonged period of time is thought to have adverse effects because of the high levels of cortisol that are in the body just naturally, and therefore get into causing negative effects in the brain.
Interesting. Thank you very much. So, oops, sorry. As for the timing of steroid administration, The idea behind the late administration of steroid is that earlier exposure with steroid treatment will result in a decreased incidence of moderate or severe BPD or death. On the contrast, early administration of steroids is more focused on ameliorating early adrenal insufficiency and thereby decreasing early lung inflammation. So the idea is a little bit different. Now moving on to the current trial, I want to talk about PICOT of the trial now first. So the population for this trial consisted of preterm babies with the gestational age of less than 30 weeks who had received invasive mechanical ventilation for at least 7 days and were still receiving it at the time of trial entry. The intervention involved the administration of hydrocortisone intravenously or orally, while the comparison group received a saline placebo. As I mentioned earlier, the effectiveness of steroid is determined by the balance of benefit and harm, and thus the primary outcome included both efficacy and safety measures. The efficacy outcome is survival without moderate or severe bronchopulmonary dysplasia at 36-week postmenstrual age. The safety outcome assessed was survival without moderate or severe neurodevelopmental impairment at 22 to 26 months of corrected age. The trial included babies who were between 14 and 28 postnatal days old and at the time of enrollment.
Can I ask Professor Waterberg a question? What made you decide in the trial design to wait until 14 days to enrollment?
Well, it was a highly controversial question. Remember, we were putting this together in 2010, 2011. And at that time, there was a real concern that the hydrocortisone was still associated with spontaneous GI perforation in the first few days postnatally. So it was a struggle to figure out how we could get people to be interested enough to be able to enroll in this trial and give hydrocortisone and not feel that they were exposing babies to a higher risk. So they ended up at 14 days because that would avoid the first week and a little bit more for safety. So as we have come to find out, especially after the Premilock trial, it does not cause an increase in spontaneous GI perforation. Do I wish we could have started it earlier? Definitely.
At that time, the correlation between the ibuprofen and the SIPs were not known, because for us it was enough reason to discard the spontaneous intestinal perforations as a serious at first, as long as you keep those two treatments away from each other.
I absolutely agree with you. It was just a very difficult study to get started in view of the reputation that steroids had achieved at that time. And we were trying to make it acceptable to a larger group.
Thank you.
Thank you very much. I will mention about the study by you, Dr. Unland later, and there's a difference between the two trials in the timing of those administration. I'll mention about it later. So I'll explain the detail of the trial now. The trial design was a double-masked placebo-controlled randomized trial conducted across 19 academic centers in the United States, including 50 NICUs. Infants were enrolled from 2011 to 2018. The study participants were infants between 14 and 28 postnatal days or with an estimated gestational age at birth of less than 30 weeks. They had received invasive mechanical ventilation for at least 7 days and were still receiving it at the time of trial entry. Exclusion criteria as described on the slide. It's major congenital anomalies and decision to limit intensive life support and so on. And as the professors mentioned, indomethacin or ibuprofen treatment within 40 hours before trial entry was excluded. So during the trial, the infants were administered either saline placebo or hydrocortisone intravenously or orally. The dosage of the medication were tapered gradually over a period of 10 days, just like in the schema.
So, Dr. Waterberg, can you explain how you came up with this dosing? Did you use some conversion? I know you talked about the mineralocorticoid and glucocorticoid activity. So, can you give us some guidance on what dose is a good mineralocorticoid activity and at what dose we receive a good glucocorticoid activity too?
So clearly a dose of 4 milligrams per kilo per day would be expected to have significant glucocorticoid activity. And giving the late after the onset of inflammation in the first week or so, I felt that we needed to have a higher dose in order to make any difference. The first week is an inadequate inadequate cortisol period. And you need to just, I thought, just bump that up a bit and see what happens with it. Whereas later you have the established inflammation that has already taken place. And you kind of need to get a higher dose in order for that to maybe have an effect. However, because it is a higher dose, we wanted to drop it down relatively quickly. And that's why we went from 4 to 2. And then by the end of the time, getting down to a physiologic dose so that it was not going to suppress adrenal activity.
So we define physiological dose as about 0.5 mg per kg per day.
Well, it depends. When you get down to an extremely low birth weight or extremely preterm infant in the first week or two, the half-life of hydrocortisone for that group is hardly ever been studied. I think we're still the only ones who've reported anything in that regard, and only with a very small group of babies. But if you look at full-term babies, their half-life in, again, a very small group of babies quite some time ago is about 4.5 to 5 hours, whereas in adults, it's 90 minutes or so. And in the very preterm infant, it's probably around 8 to 12 hours. It's very difficult to tell, of course, because it's the same as native cortisol once you get it into the baby. So that's why we went with the dose that we did. And I forget the last part, but yes, so physiologic dosing for the very early, very immature baby, I feel would be about 0.5 milligrams per kilo Q12. And with that, you can see changes in blood pressure and other signs of systemic activity. However, once you get up to 32, 34 weeks, you're seeing maturation of the baby, him or herself. Therefore, you probably need to dose it more frequently, like every 6 to 8 hours, and see if you can make the difference that you want to there.
Yeah.
So it changes. It's very hard to figure out an individual dose for a baby until you figure out what their corrected gestational age is.
Yeah, that was a very helpful insight. Kosuke, you want to proceed?
Mm-hmm. So now moving on to the randomization. The randomization process involved assigning the participants in one by one ratio. This was conducted by the NRN Data Coordinating Center at RTI International. The randomization method used was permuted block randomization, which blocks of 2 and 4, and with blocks of 2 and 4, and stratification was performed within each center based on gestational age. Regarding blinding, the pharmacy personnel prepared the masked hydrocortisone or placebo to ensure blinding, keeping the trial group assignment undisclosed. All other personnel involved in the study remained unaware of the trial group assignment, maintaining the blinding throughout the trial.
So Kosuke, can I just make the point that it's very important that
Mhm.
stratification occurs within the center
Mhm.
because inter-center differences in multi-center trials are larger than any outcome effect that you might
Mhm.
actually see. So
Yeah.
you have a wide variety of outcomes, and it's really important when you're looking at this in
Mhm.
other studies that they took into account the center.
Hmm.
Mhm. Thank you. So the primary outcome assessed in this study were efficacy and safety. For efficacy, the improvement in survival without moderate or severe bronchopulmonary dysplasia at 36 weeks of post-menstrual age was measured. Additionally, an ambient air challenge was conducted for infants who were receiving FiO2 less than 0.3 through a nasal cannula. And in terms of safety, the outcome measure was survival without moderate or severe neurodevelopmental impairment at 22 to 26 months of corrected age. Neurodevelopmental impairment was defined with Bailey-III cognitive composite score or motor composite score, gross motor function classification system, severe vision impairment in both eyes, or bilateral hearing impairment. The secondary outcome evaluated in the study included standard complications, growth measures at 36 weeks of postmenstrual age, growth measures at 22 to 26 months of corrected age, successful extubation during the intervention period, use of open-label dexamethasone, and respiratory status at 40 weeks of postmenstrual age. Because they did not have hypothesized effect sizes, so for the secondary outcomes, only the conditional power and the current trend was computed for these outcomes. Specific adverse outcomes of interest that were monitored in the study included spontaneous gastrointestinal perforation, sepsis, hypoglycemia, and hypertension. In terms of statistical analysis, a sample size of 800 infants were chosen with 80% power to detect a 10 percentage point increase in survival without moderate or severe bronchopulmonary dysplasia from a baseline survival rate of 35% or less, as estimated from NRA data. A two-sided type 1 error rate of 0.05 was used. With this sample size, a significant benefit was not expected. For the safety evaluation, it was considered successful if the hydrocortisone group had a lower risk of death or neurodevelopmental impairment compared to the placebo group. Alternatively, if there was a higher risk of death or neurodevelopment impairment in the hydrocortisone group, the lower limit of one-sided 95% confidence interval for the ratio will increase benefit from bronchopulmonary dysplasia to increase risk of neurodevelopment impairment was required to be more than 4. Fertility analysis were conducted when evaluating the data from 400 and 600 infants. All analyses were performed according to the intention to treat principles, meaning that all participants were analyzed in the groups to which they were originally assigned, regardless of their adherence to the treatment protocol. Now moving on to the result, I will show you the participant flow. This is participant flow. 1,523 infants were excluded from previous receipt of glucocorticoid, and only 339 of these infants had received glucocorticoid therapy for BPD, which represents 3.4% of the ineligible infants 800 infants were enrolled and underwent randomization. 2-year outcomes were known for 91% of the infants. This is the table for maternal and infant demographic characteristics. The mean birth weights were 710 and 720 grams in the two groups, respectively, and the weeks of gestation were 24.8 and 24.9 weeks. Baseline characteristics did not differ substantially between the two groups except for sex, with more boys assigned to placebo than to hydrocortisone. At the beginning of the trial, roughly 1/3 of the infants received high-frequency ventilation, and the remaining 2/3 received conventional ventilation. To those eligible but not enrolled and were representative of the wider population affected by bronchopulmonary dysplasia. This is the primary outcome. At 36 weeks of postmenstrual age, 66 of infants in the hydrocortisone group were alive without moderate or severe BPD, which was 16.6%, compared to with 53 infants in the placebo group, which was 13.2%. And it was not significant. Results for components of the primary outcome were similar in the two groups. And in the safety outcomes, survival without moderate or severe neurodevelopmental impairment at 22 to 26 months of corrected age occurred in 132 infants in the hydrocortisone group and 134 infants in the placebo group, again without no significance. In the secondary outcome, the severity of in survivors was similar in the two groups. The hydrocortisone group had fewer days of mechanical ventilation than the placebo group. Similar numbers in each group had been extubated by 36 weeks of postmenstrual age, and total duration of supplemental oxygen therapy and length of hospital stay did not differ between the two groups. Open-label dexamethasone was administered to 39.7% of infants in the hydrocortisone group and 42.1% of those in the placebo group.
So, Dr. Waterberg, I think it's a good time to review your experience with the trial. It took almost 10 years from inception to completion. What the hurdles you faced in this trial and what the results you were expecting. How does that change your future trials and things like that?
It did take a long time. The population that had been intubated at 2 weeks prior to the support study was what we used as data to set the expected anticipated numbers for this trial. After the support trial was completed, fewer babies were intubated and fewer babies were intubated continuing at 2 weeks. Therefore, it took us longer. The other thing was that, as I said, at that time, some of the people involved were very much concerned about the use of any steroid in these babies. And we spent a great deal of time doing site visits and phone conversations to try and acquire a little more equipoise. That became easier as time went on. People became more interested in giving steroids. And I faced it on both ends. In one center, someone might say, we're never going to give steroids, and I'm not sure why we're doing this study. In another center, they would say, I want to give dexamethasone prior to 2 weeks, and therefore I'm not going to put kids in your study. So yes, it took a while. The other reason it took so long was because we said we were not going to report out short-term outcomes until we had long-term safety outcomes in hand. We've certainly seen, particularly with dexamethasone, the results of publishing short-term studies without long-term safety data. So we were not going to do that. So yes, it took quite a while to get it done. I'm sorry, but what was the next part of your question?
So the question about the use of dexamethasone being high and stuff, do you think that affected the study or the higher amount of females in the?
It's a high degree of contamination with dexamethasone therapy, certainly. However, it seems to me that people use the same kind of criteria to start dexamethasone, and therefore it's about the same. It's about the same as the difference we saw in outcomes. It's about 3% difference. So I don't think it made a difference in what we saw for the outcomes, but it clearly would have been cleaner without that contamination.
Yeah. So Dr. Onlin, the practice in Europe does that also have about 40% of these babies get dexamethasone, or the use of dexamethasone a little different?
Let me answer that one after I make one comment, or actually a compliment to Professor Waterberg, because we have to emphasize that this is the largest steroid trial, a huge accomplishment, because in fact it is a very delayed trial, which makes it very difficult to get informed consent, to keep the researchers, the PIs enthusiastic. As a trialist myself, I only can make a huge compliment of accomplishing this trial. Very important. So regarding the dexamethasone rate, that is rather high, but you have to bear in mind that is a very highly selected population of 12,000 infants screened, and eventually 800. That's about 9% of the population. So these are the sickest babies there were, and probably still are. I have one question for the audience, for Professor Waterberg, for somebody, because what I experienced is that although we say that it is a double-blind trial, in our own trial, we knew pretty sure which baby got hydrocortisone, which didn't, and that's the problem with corticosteroids trials. You see at the bedside the improvements steroids cause. And even though we are very interested in the long-term outcomes, either BPD or neurodevelopmental, the nurses tell us which arm the infant is allocated to.
I agree that's an issue. I would point out, though, that for the previous dexamethasone trial that the network did, which was quite a ways back, I think it was in the mid-90s, Dr. Papil was the first author on that. They did ask the staff, the bedside nurses, whether they thought the baby was getting dexamethasone or placebo. And it turned out that they were right about 50% of the time. So I agree with you. It really seems clear who's getting the drug, and I'm not sure what would happen today if we did the same question, but yeah, that's what they found.
Yeah, as I said, all these trials take a lot of effort, so I hope our trainees are encouraged to push forward if they are facing some setbacks. Kosuke, you want to proceed?
So this is the figure for the infant extubated according to day of treatment. During the treatment period, more infants in the hydrocortisone group were successfully extubated than in the placebo group. It's obvious. This result doesn't support the idea that early extubation leads to improvement of BPD. Let's move on to the discussion part. In this trial, hydrocortisone treatment did not lead to higher survival without moderate or severe BPD than placebo, nor did hydrocortisone treatment alter the severity of bronchopulmonary dysplasia. So the result didn't support the hypothesis I mentioned at the beginning that earlier exposure will result in a decreased incidence of BPD or death. In contrast, survival without moderate or severe neurodevelopmental impairment at 2-year follow-up was similar in the two groups. There is a large multi-center randomized control trial. Hydrocortisone treatment began after the first postnatal week conducted by on land in the Netherlands and Belgium at almost the same time. The studies differ in the timing and length of the intervention. Just we've just already discussed, but the results are consistent. I have discussed late hydrocortisone therapy so far. On the other hand, is early steroid not also effective? There is a large randomized control trial called Plemiloc trial conducted by BOD in France. Of the 255 infants assigned to hydrocortisone, 60% survived without BPD compared with 51% in placebo, which was significant. However, there were no significant difference in the outcome of death alone or BPD alone. Oops.
So, Dr. Waterbuck, you want to comment on this trial? What the results of this trial? I think that your trial was halfway through when the results came out. Were the results encouraging for you that maybe the late will also work because the early clearly showed a benefit in the short-term outcomes?
So clearly we were very disappointed with the results of this trial, but not terribly surprised because, as I said, we had previously shown that there's an increase in airway inflammation in the very first postnatal days. And giving hydrocortisone in the first postnatal week or so would make sense in decreasing that inflammation and potentially decreasing inflammatory injury. Whether we could achieve that same thing at 2 to 4 weeks was clearly unknown at the time and maybe less promising. So I don't know if you're going to talk about the individual patient data meta-analysis of the early hydrocortisone trials, but they all agree with the idea that it's helpful.
So there's a meta-analysis in Cochrane database conducted by Doyle in 2021, which includes Plemiloc trial. There, these are the forest plots in the systematic review. Hydrocortisone reduces mortality and the combined outcome of mortality or BPD at 36 weeks of postmenstrual age, but has little to no effect on BPD at 36 week postmenstrual age. Early postnatal steroids administration is often given to treat hypertension, just mentioned in the paper we discussed today. So the improvement in mortality is not necessarily due to improved respiration. Stabilization of circulation by prevention of adrenal insufficiency may contribute.
So, Dr. Waterberg and Onlin, can you walk us through this meta-analysis that, yes, there is some improvement in mortality with the early low-dose hydrocortisone, but not much is seen with BPD and I think even with NDI. So how do we interpret these results into our practice?
So my concern with this is the inclusion of several studies with very different design. The Biswas study did not, I think they did not go into the second week. They were looking at its effect on, they were looking primarily at thyroid effect on outcomes, and they gave hydrocortisone so that you didn't get adrenal insufficiency secondary to increasing thyroid hormone. Efford was looking at hypotension, as was Ng, and they did not treat for a very long period of time. I think it was Efford was maybe a couple of days and Ng was 5 days. So I'm concerned about putting together studies which have different designs and different intents. That's why when we did the individual patient data meta-analysis, we looked at the studies that were designed with the primary outcome being the effect on survival without BPD. And there we did find an effect, as I said.
Yeah. Do you mind us reminding the effects and the results you found for us?
That it was statistically improved mortality or improved survival, and it decreased BPD.
Yeah. And was there any change in neurodevelopmental impairment noted?
No, that was a little bit harder. We couldn't do an individual patient data meta-analysis because the different countries, there was Finland and Italy and ours and France, and those countries used different tools to assess neurodevelopment. But looking at the combined outcomes at 2 years, there was no impairment of neurodevelopmental outcome. Wes, your take on?
Yeah, a comment about these forest plots. It's not only the different trials, but it is also picking one component of the composite outcome you're aiming, your objective is. So what you have actually is a secondary outcome, and it's dangerous to, you have to be cautious interpreting those results because they are not primarily aimed at reducing mortality. You have a problem with correcting for multiplicity in your trial. That's why the high impact journals want you to state that the primary outcome is death or BPD, and one of the components is a secondary outcome. Then you have to really be, it's hypothesis generating. So, and now putting then all the mortality rates together, you still have to be careful about interpreting and saying that it is significantly reducing death. That's one. And one question for Professor Waterberg is, as I recall it, what always intrigued me in the IPD analysis is that what you would expect is that it would be most beneficial in those infants with the lowest gestational age. But when you look at those sensitivity analysis, the most increased effect of hydrocortisone, low dose infant, is in the higher gestational age groups. And that's also what our problem with the Premilog trial is. The respiratory strategy in Europe is probably somewhat different, or in the northern parts of Europe is probably some different than France. The number of patients intubated in the Premilog trial is about 50% during the first week. That means that 50% is off the ventilator and 50% stays on the ventilator during the first week, even when you're 26, 27 weeks. And when you look at the Dutch figures on ventilator use, then it's about 10%. So we do not use early prophylactic hydrocortisone, because if you do not harm the infants by using a ventilator, you do not have to treat it by using hydrocortisone.
Yes, and my studies were done in ventilated infants only. So I agree with that. I don't want to give an anti-inflammatory agent to a baby who's not experiencing inflammatory stress. Also, things have changed a great deal since those original trials were done in terms of, like I said, the support study really decreased the number of babies that were primarily intubated. So as always, by the time you get the results of a study like this, things have changed, and you say, well, I don't know what it would be like today, but you do what you can and you move on and try something else.
So I think
with our trial in the second week, we had exactly the same problem. We started out thinking, well, it's going to be 3 years of inclusion, and then we ended up 5 years because we got really restrictive in ventilating even in the second week of life.
Yeah.
But that also changes the profile of an infant of a high versus a low risk of BPD, because we're even when you're on a CPAP, we accept a much higher degree of FiO2, and eventually these infants end up having BPD as well.
Right. I think Lex Doyle has published some interesting information out of Australia that although the babies are not being intubated for as long, we are not seeing a decline in BPD or severity of BPD. So yeah, we have to keep figuring out new things.
So bringing to the point of the late hydrocortisone, do you think, is there any specific group of infants who would benefit from the late hydrocortisone? At least from the Premilog study, we have some results which showed that, placenta pathology, like specific babies, may have much higher effect compared to the general population. So is there a subgroup which will benefit from this treatment?
Well, that was definitely an area of my primary interest, was looking at the effect of prenatal inflammation on outcomes. And we found that those babies had a lot higher increase in BPD rates. The thing about it was, that's another reason I wanted to look at the first week of life, which is when that inflammation is at its highest. And so you need to maybe give them a bit more help in order to get that done. By the time you get out to the second, third, and fourth week, I'm not so sure that you can distinguish between those groups anymore.
So do we think that like choreo babies would have a probably larger benefit of hydrocortisone early or
We
late?
did see that in our subgroup analysis, again, exploratory, but we looked at subgroups by sex and gestation and chorea amnionitis, and we did see that that was more beneficial to babies who had chorea amnionitis. They had a much better result from the hydrocortisone treatment, and we had seen that in my first study as well, the prophylaxis study that I published in 2004. That the babies who had histologic evidence of chorea amnionitis, and that was all by one central reader for that study because we were so interested in the effects of chorea, and that made a big difference to those babies.
So should we consider this as just an exploratory analysis or hypothesis generating, or should we incorporate that into practice, given the results of yours and Dr. Onlin's study?
Oh, golly. I hear all different takes on that. And, I've been around for a long time, and I think that people have to take what they see and they have to apply it to their own specific individual institution. And people have different rates of BPD. They have different rates of chorea amnionitis. They have different ways of approaching babies. And I think that you need to take a look at your own individual institution in terms of the rate of BPD and all the rest of those factors and decide whether or not you think that should be part of your practice.
Dr. Onlin, you want to comment on the subgroup analysis?
I totally agree with Professor Waterberg. I think the way forward is identification of subgroups of infants. You have infants with highly inflamed. You have infants that are have a growth restriction. Both end up having the label BPD, but it's probably a different BPD of the a different causal path. And I think we have to put some effort into identification which path it is, and then try to target the right patient. And one of the things we're doing is examining exhale breath to see if you can identify some molecules of inflamed infants versus non-inflamed. And then you can target or you can set up a design of a trial, also including non-invasive ventilated infants. Because what we did, I think so, in the Stop BPD trial, is we were too late. Those infants that we included already had some kind of a point of no return. Whereas we should target earlier, but with the right identification. Those who really need it should be treated, and those who don't should not.
Absolutely, I agree with that.
Yeah.
The moms with preeclampsia, the SGA babies, those are very, very different babies than the ones who have preterm labor, preterm rupture of membranes. Those are the babies more likely to have inflammation.
Yep. So as they say in science, we stand on the shoulder of giants. So this great work done by Waterberg still have a lot of avenues to explore in the future for the new trialist here. Koske, you want to proceed with your final slides?
Mm-hmm. So there are a few slides left. Regarding the adverse event, hypertension was the only adverse effect observed more frequently in the hydrocortisone group, while the incidence of culture-proven sepsis and necrotizing enterocolitis were comparable between the two groups. Moreover, the utilization of systemic glucocorticoid within the 14 days trial period or later was similar in both groups. And strength of the study include its multi-center design, which reduces biases already Dr. Watterberg mentioned, and large sample size. The study also benefits from a well-established multi-center clinical trials network. Furthermore, the certification of all examiners performing neurologic examination and baseline assessment at 2 years add credibility to the study results. However, the study has some limitations. Firstly, only 35 of the eligible patients were enrolled in the study, which raises concern about potential selection biases and the representativeness of the study population. Secondly, there is a high incidence of subsequent treatment with open-label dexamethasone, which may confound the interpretation of the results. Thirdly, the eligibility criteria only included infants surviving to 14 days, potentially excluding a subset of the population that could have provided valuable insights. Lastly, the outcome were limited to a 2-year follow-up, which may not capture long-term neurodevelopmental outcomes.
So just to comment on that, just to let people know that we are in the process of conducting 5 to 6 year outcomes on these babies. And in 4 of our centers, they're able to do pulmonary functions. And so we're looking at pulmonary functions in that group of infants, in the ones from the transfusion trial who were less sick, and comparing that to healthy term babies. So I'm very hopeful that we'll have good pulmonary data and other functional outcomes in these kids at age 6 pretty soon.
Thank you. So this is the last slide. So previous studies suggest that hydrocortisone administration as a treatment for BPD may be effective in the early stage of the disease. Research question for future research includes, I think it's already professors mentioned, but identifying the optimal strategy for early hydrocortisone administration, determining whether early corticosteroid treatment leads to longer-term survival without neurodevelopmental impairment, and developing a strategy for the late rescue administration of steroids in the management of bronchopulmonary dysplasia. That brings me to the end of my presentation. Thank you for your attention.
Yeah.
Very
Costa,
nicely done.
Yeah, great presentation.
Thank you very much.
So I'm gonna take a few questions from the audience. I have a question. Is there a role for serum cortisol levels to indicate and manage steroid supplementation? Dr. Watterberg here worked a lot on this domain, so.
Yeah, so for a long time, I was getting cortisol concentrations prior to treating, but the variability intra and inter individual really overshadows the value of any particular cortisol concentration that you get, with the exception of babies who have high cortisol concentrations. Those babies were the ones that were at highest risk for spontaneous intestinal perforation. And it might be valuable to know who that is before you decide to treat, and maybe not treat the babies whose values are over, say, 15 or so.
Yeah, that's very interesting insight.
And maybe I can add something, because maybe we should not look at cortisol alone. Cortisol is, of course, a product of precursors, and some of the preterm infants are not able to activate or to transcript it from the precursor to actually cortisol. So maybe we should take a bundle of precursors and cortisol to determine whether the infant should react on an inflammation. And it's a sort of disbalance between inflammation, where you should react with a higher cortisol activity, versus those infants who are not inflamed and should be at ease adrenal wise.
Yeah, we did some work on that when we were first starting to look at how cortisol related to BPD, and we found indeed that there were higher levels of precursors relative to cortisol in the babies who went on to get BPD. Very consistent with that hypothesis.
Yeah, in a way, I think the use of budesonide with surfactant is a way of giving very early glucocorticoid in that regard.
And we're all looking forward to your study, Ambal.
Yes, well, I think the PlusS trial from Australia will probably be, I mean, it's already finished enrollment. They should have results presented at the Hot Topics later this year. So we may have data from that earlier. But one thing I was thinking is it may be possible to also use the NICHD BPD estimator to actually have a more targeted approach to which infants may be the highest risk and also the most likely to benefit.
I'm definitely for that concept. What we need before we can design in Europe such a trial is validate the BPD estimator on European data. But once we have accomplished that, I'm definitely going to get the doctor on the ward out of the equation before the inclusion begins, because I think that's a big problem. The doctor is deciding whether the infant is intubated or not, and thus influence the trial. I want an objective tool to decide whether it's a high risk of BPD, and a BPD estimator tool might definitely be a tool to use.
Yeah, I agree. I think it's going to be really good. For this hydrocortisone trial, we had very specific extubation criteria, and all the people agreed that they would extubate a baby at that time. So we didn't have very many people who did not extubate when they were supposed to. So I think that was one strength of the trial, and may have been why we saw a decrease in the length of intubation.
But I'm going to tell you a little anecdote to show you why I want a doctor definitely out of the equations, because while we did rounds around the different centers of the Stop BPD, and I noticed that during recruitment, one center was going really high to really low. And I asked the doctors there, what happened there? And they said, well, we changed from one ventilator, CPAP ventilator, to another. And the first ventilator made such a noise that we rather intubated them than put them on CPAP. And well, we got a new ventilator, so there are no infants intubated anymore. So we don't have any recruitments. That influences your trial, just to keep it among us.
So selection bias remains a huge problem in conducting all this BPD trials. So given the results of the individual initial participant meta-analysis and probably combining with the BPD estimator, do you think it should be a practice changing that we should start giving early hydrocortisone, or we should wait for the results of a trial and specifically asking this question?
Which trial would be asking that question now?
Should we use early hydrocortisone who are at high risk of BPD, or should we give it to all? Should we start changing our practice? Because as far as I can recollect, very few people still don't use early hydrocortisone.
Right, and I think that we have to be selective, as Wes has pointed out several times, in who we are treating. So if you look at the tiny babies that we are including in this study and included in that meta-analysis, their risk in general is greater than 50% for death or BPD. So I think we are trying to target a high-risk population. And personally, I would, as we've said, try and avoid the preeclampsia babies and the ones who are born from maternal indications, and try and stick to the group that is born for preterm labor or preterm rupture of membranes, which usually has to do with inflammation being present.
Yeah, I think that was a great insight on just learning how inflammation influences our treatment and risk for BPD and what we can do about it. So any closing comments? Dr. Onlin, you want to start something to inspire the trainees on the sessions?
I think, like I said in the beginning, that BPD is very complex, and it's a complex between trying to be as restrictive in your ventilation as possible versus targeting the right person who needs the steroids to not to get into a cascade of pro-inflammatory causing BPD. But we also have to use the upcoming tools, the BPD estimator, after we have shown that it does definitely impact treatment. Not just get it into practice, but first do a trial showing what the impact definitely shows.
Yeah, that's very helpful. Dr. Waterberg, any final closing comments?
No, I think that this kind of a forum is really helpful and important, and I hope that people can take it back with the understanding that what you need to do, like Wes said, he needs data from Europe. We need data from individual institutions. You need to know what your outcomes are before you decide to institute any therapy, and in particular this one, because it is a powerful one with side effects.
Yeah, I think this was a great session, a lot of wonderful insight, and Kostka did an excellent presentation. So I'm very grateful for everyone who attended. For our next session, we travel all the way to New Zealand and Australia on July 27th. So we hope to see you again then. Thank you very much for everyone to join in. And thank you, Dr. Humble, for chiming in too. Thank you, everyone. Bye.
Thank you, Kasuke.
Thank you very much.
Thank you very much.